Is it okay? Um, why it's so high? Good morning, everyone. I thank you all for the attending this upcoming session. And at the onset, I wish to thank KSOS. May I invite the panelists of this panel discussion onto the dais? Everybody is talking. No, everybody is busy. May I please invite all the panelists for this session onto the dais? Dr. Sai Kumar, he was very good to agree at the last minute when Dr. Ronnie couldn't make it for the session. I invite Dr. Sai Kumar to the dais on the left side, followed by Dr. Thomas George, Dr. Ganesh Raman, Dr. Girija, and Dr. Lopamudra Biswal. So in the next 55 minutes, I'll be presenting a few case scenarios and open it for discussion from this expert panel whose names don't need any introduction. Sai sir is known to all from Giridhar Eye Hospital, Dr. Thomas George from Chaitanya Eye Hospital, Trivandrum, Dr. Girija from Little Flower, Angamali, Dr. Ganesh Raman sir from Arvind, Coimbatore, and the upcoming young ophthalmologist, Dr. Lopamudra Biswal from Chaitanya, Trivandrum. So I think Ganesh, we can't see you. I think you can sit next to Dr. Sai probably. Okay. Okay, so this patient, he's a 70-year-old gentleman who came to the glaucoma clinic, referred from the retina clinic with this visual field. He had asymmetric cupping with this visual field in the left eye, the left more than right cupping. And his intraocular pressures with Goldman was 20 millimeters of mercury. He had thick CCT about 575 to 580 micrometers. And his left disc had a large cup with a sloping inferotemporal pale NRR, and this is how his fields are. You can see the 32 octopus program on the left side with the superior arcuate and the 10-2 and the macula top programs showing a superior arcuate very close to fixation, but fixation spared. And he's a diabetic and hypertensive on treatment for 14 years. And I started him on prostaglandin analog, travoprost, and brought down his pressures 25 to 30% from the existing 20. And he went on with 14 millimeters of mercury. So it's a unilateral glaucoma. And between 2018 to 2019, you can see the SLV has progressed from 9.7 to 11.2 dB. And that's when we asked him to go to the physician and get a cardiology checkup done, a hypertension status to be reviewed. And amongst the galore of investigations, he was found to have obstructive sleep apnea that time and began to use his CPAP from 2019 onwards. Despite it, from 2018 to 2020, if you see his C32 programs, here also the SLV is showing a subtle progression in its steepening of defects from 5.5 dB to 7 dB. And that's when a further look from 21 to 23 on the left-hand side, you can see the superior arcuate in the 10 degree in the 10-2 is progressively worsening with the SLV increasing from 10.1 to 11.2. And that's when his sons also were diagnosed to have obstructive sleep apnea, which strengthens the diagnosis of the sleep apneic process to the whole progression of unilateral glaucoma. And he also told me that he was not using his CPAP properly. He decided to use it more in a stricter manner. And still, as you can see on the right-hand side, the 32 programs, by the time from 2023 to 2025 January, it actually, though the 30-2 is showing more or less not much of a steepening, the 10-2 is showing a progression towards the inferior hemifield. So what to do now, and this is how we decided that the 10-2 probably needs a closer follow-up than an annual field. So here we have a progression despite a strict CPAP, IOP is maintained at 14, compliant patient on 2 medications, initially on prostaglandin analog alone, but when the obstructive sleep apnea process was detected, we added a beta blocker. Then it so happened that when we went for cardiology checkup, he was found to have an LBB, left bundle branch block, so the beta blocker was replaced with a brinzolamide. So on these 2 drugs, his IOP is in the range of 14. And because of this visit showing an inferior field progression in the 10 degrees, I forced him for looking into his disc. This is what the disc picture showed in the left eye. So how should we go about it next? From 2018, 2019, diagnosed obstructive sleep apnea, and the 10-2 showing subtle progression all the way through till Jan 2025, and now we see a fresh disc hemorrhage. I would ask how to go ahead further, Dr. Ganesh.
So in a patient who is treated for glaucoma and for hypertension and diabetes, if I see a disc hemorrhage, I would really think of uncontrolled blood pressure or uncontrolled systemic condition. So of course we have done significant amount of systemic work for this patient. I will also add ambulatory 24-hour BP monitoring.
Yeah.
So that's something which I would strongly look into it. Disc hemorrhages which happen on the margin in treated patients may not signify so much of glaucoma related component, whereas if they are within the disc, I would strongly think of glaucoma progression. So in this patient, I would do that first, and then further tests. The other test which I could even think of is ocular blood flow analysis, but that will be a little later. Not everybody has access to it, so I won't push that. But yes, control of diabetes, that is, they should at least make an effort. Number one. Number two is look at the ambulatory BP monitoring.
Okay, Thomas? Anything to add on?
I don't know, maybe we'll do an OCTA, but the OCTA would only prove things that we can see already on the fundus. If you look carefully, left eye has got the lower IOP and left eye is the one that's progressing still. And if you look at the fundus, you have a wider peripapillary atrophy in the left eye, and there is a dropout of choroid capillaries. You're seeing the big vessels, almost a choroidal sclerosis in both eyes, with that being worse in the left eye. So you got vessel changes there which we can't do anything about. So we are just going to keep following up, hit the lowest IOP possible. And theoretically, Korea has got a lot more of NTG than we have. And those guys do a trap aiming at pressures like 4 to 6 in a situation like this. Having said that, please don't refer to me.
Girija, anything to add on?
This obstructive sleep apnea, it can cause so many vascular problems also. So was a Doppler done? Carotid Doppler?
Carotid Doppler was done. It was normal.
Because it's unilateral usually.
Yeah, it was done and it was normal in the...
So the vascular cause, maybe, as Thomas pointed out, that could be one thing that has led to this.
Yeah, so ABMP, like Octa, and like you said, carotid Doppler study of the blood flow analysis are all important investigations in such unilateral progressing. Anything, Sai, sir?
No, I think Thomas has said not to refer to him. But I think, don't you think this is a surgical case? What are we waiting for in this case? You have a unilateral aim for a very low pressures, if possible. No, the patient is still progressing. You're having fresh changes here and there. Part of it is vascular, I agree. It is not purely mechanically induced. Part of it is vascular. But I don't know.
So how low would you aim at? Below 10 for him?
Definitely below 10. Definitely below 10. It's very difficult to titrate and say I will get 10 in this case.
Yeah.
Very difficult. Especially if the patient has been on long-term prostaglandins with bad conjunctiva and things like that. But otherwise, possibly I would think in that direction.
Okay, but
also if you're operating before it's macular split.
Before?
It's the fixation is split.
Yes, before there's a fixation.
After that, it's even more dangerous.
Yes. Lopa, anything else?
the BP for 24 hours.
Yeah, that's all said.
Yes, and
Anything
keep
extra?
The IOP in single digit.
Okay. So all of you agree, we agree with all of what you have said. And
just one thing.
just one more thing. The
I would
third,
like to say that if he has a tendency to sleep on the left side, that side will progress faster. So you have to see that. And provided he's not a smoker, smokers will have something like smokers polycythemia, and they will progress asymmetrically.
okay. So the thing is that he went back to his pulmonologist and it was found that he had bought an online mask and that was not very well fitting. So his technician has changed it into a tighter mask and smaller mask which fits him well. That is one thing. Then like Dr. Ganesh said, he went back to one of the leading cardiologists at Trivandrum and it was found that there was a lot of fluctuations in his BP. He was on Silacar at night, which was changed to morning dose. And despite it, there was a lot of fluctuations in BP. His early morning BP was 160 by 100 and had significant BP fluctuations throughout the day. So that was also rectified. The Silacar was made once daily and an antiplatelet agent was added. And we added one more medicine, though Sai will be irritated, but one more medicine to bring the pressure lower. And the DVT was done on the medication revised and to see what the range of fluctuation was. And it fluctuated from 11 to 13 millimeters, just about 2 millimeters of mercury. And with that, one thing, looking back into his OCT of 2022 and 2024, one thing I probably would have missed on is the supratemporal early clock hour thinning in 24, which probably was not given much of a weightage. And looking back now, if you're doing a scrutinizing a disc presenting in 2018 itself with such a large cup, such kind of supratemporal thinning is always going to be missed. So one thing in this case, a take-home message is always revise your diagnosis, scrutinize to detect any early progression, assess cataract and rule out its interference with visual field interpretation, and periodic gonioscopy in every progressing case. Okay, move on. And this is his...
Second, Meena, before we finish, I would like to ask Ganesh, I mean, what is the theory behind, other than the sleeping on the left side? Why so much unilateral? Are we giving too much emphasis on the sleep apnea part?
The other thing which, like the fluctuating BP, why that happens, if you notice, it happens invariably in males. Okay, that fluctuating BP happens because they also have some concomitant prostatic hypertrophy. They go to bathroom at night and that disturbs their sleep, and they go in an emergency. They may go to visit the bathroom 3 or 4 times. So the early morning BP spikes. And they may also present with subconjugal hemorrhages. So that's another reason. So now when they sleep only on the right side, they don't only just sleep on the right side or the left side, they press the eyeball. That is constantly happening for the last 40 years. It will cause a damage when they become old age.
Once again, this sleeping on one side is from Korea, the paper. They have a lot more NTGs than we have. And it's not just the pressure, it's also their postulating hydrostatic difference between the two eyes and things like that for those 2 inches. Huh?
Thank you very much for this info. Dr. AB, anything to suggest from this case?
I will concentrate on the blood pressure as well. We need a 48-hour blood pressure and also a diurnal variation of pressure as well. The drop blood pressure. 2 of these things also we need to.
Okay. Okay, so after all this correction and realization in Jan, we did Spiels after 6 months at 10-2 and it was stable, fortunately. So we carry on like this till we plunge on to surgery if he progresses next. And the next case, this patient is again a 75-year-old gentleman who went through an uncomplicated routine cataract surgery. He was not a known glaucoma patient. He underwent the right eye first on 11th and the left eye first next on 27th in 2022, and then once he got his good vision, he never came back for any follow-ups after 3 weeks. That is a second follow-up, post-cataract follow-up visit, and he came back 3 years later with a little diminution of vision in the left eye, and though the vision was normal, his pressures were 42 with not much of an edema at all in the cornea, and this was a picture of his anterior segment. You can see against the 3 to 4 mm pupil, you can see the fine pigments on the IOL surface. And this was his specular just before the surgery, just to show that the cornea was 487, it has come up to 514. And these are his angle pictures which show the dense pigmentation of the posterior trabecular meshwork in all the 4 quadrants in the left eye. And when he came to us in after 3 years of no follow-ups. This was how his disc was on the left eye. It's a moderate to advanced glaucoma, and this is his 32 program on the left eye in the octopus field, which shows an incomplete double arcuate and a fixation spared on the 10-2. And the interlight OCT showing the asymmetric thinning bipolar in the left eye. So here we have a secondary open angle glaucoma, mostly related to pigments. And it's in the short time of 6 months, he is on medications, initially on 3 drugs, but sometimes he doesn't think it's serious, so he used to not put medicines. And that's why when he came with again an IOP rise sometime in June, we added the 3rd drug with combination of Trisopt, and his pressures are now in the range of 12. But I would ask you, like the panel, what are the possibilities in your mind as to why so many pigments on the IOL unilateral, same IOL put, same surgeon, and
The right eye vision was normal, no? It was
both eye vision was
a
6.6.
printing mistake. You had written 660.
Oh, sorry, it was 6.
Yeah, no, no,
660 is
just-
before
just
surgery
to
for
make-
both eyes.
Just to make sure. Okay. So, so we have a unilateral case with a lot of pigment release, and we are almost sure that the pigmentation is the cause for the glaucoma. So whatever is releasing pigments from the iris post-op, UBM?
Yeah,
UBM
so
was done?
yeah, UBM was done to know whether the haptics are in the bag. And I'm very sorry about this. I put up this print, so you can't individually see. But the haptics were in the bag in all the clock hours.
What was the intraocular lens that was used?
It was the Alcon single piece acrylic
series.
IOL, yeah.
KSOS series.
It's in the bag, but I think Thomas has already seen this print, so I will not keep him in the picture. Anybody else can comment on any other Girija, anything from the UBM? Because Thomas had come up with what possibility from the UBM. I showed him this print then. I was quite sure it is in the bag. Then why so many pigments unilateral was the question that arose. Anybody can put in a suggestion. Thomas came up with this, I don't know if you remember now, but he told it could be a flipped IOL. And then looking at this anterior surface of the IOL, see the contour of the IOL, I too thought probably, is that what gave you a hint it could be a flipped PC IOL?
The thing is, typically the IOL, the posterior convexity is supposed to be more than the anterior convexity when we place it. And here, it's the other way around. So it's
So much gap between the IOL
but
and
yes,
the iris
yeah.
if you see the UBM.
Yeah.
So the thing is, it is sticking out more in the pupillary area where it's exposed. The pupil edge can still hit it, not the mid periphery. That's one. Other thing that I would think of in any post-op case is that we are seeing a lot more pigment dispersion ever since we started using intracameral moxie.
Okay.
That is also BAT and BADI. That can happen this situation also, and we are probably seeing 2 years down the line, and which is why it's medically
But
controllable.
why unilateral?
It's always unilateral because that side the dose was a little more than the other side. We are not really titrating the amount that goes in.
Yeah, the other thing is where we inject it. If you have a tendency to inject it behind the pupil, behind the iris, then you'll have this. So our chairman always says that don't inject it behind the iris. Inject it in front or inject it intracamerally, but don't make an effort to go behind the iris and inject the moxifloxacin. And this flipped IOL was, I think this is, it's a bouncer to me.
So as long as the pressure is going to remain like this and the fields are going to remain like this is a very short period of May 25 to November 25. What to do next if he comes up with a spike?
Surgical manipulation can cause unilateral like this.
The other thing is if the rexis on one eye is appropriate, the other one is larger. If it's not a flipped IOL, then the haptic optic junction can be little anterior, and that can cause this. Optic edge can also cause.
So, Dr. Sai, what would your opinion be? Isn't it going to be difficult taking off the IOL?
How many drugs?
Now he's on maximum. Trisopt with travoprost. That is 4, which is actually not allowed. What if his field worsens next? What do we do?
Operate.
Not to remove the IOL, right? Cannot even.
No, that's going to be because
Very
you've got good vision.
Yeah.
So removing and maybe using a sulcus fixated IOL, there's no guarantee.
So glaucoma
that
filtration
pigmentation-
surgery. Not to touch the IOL, isn't it?
Absolutely. The IOL is just a postulate. We are really not sure. We may be still
Yeah.
looking at bait or badding.
Yeah.
The, long-term pigment dispersal post-surgery.
Huh. Okay, so next I go through 3 cases, post-acute angle closure cases. After the first and second, we'll go for a discussion. This patient, she actually presented to us 3 days after an acute attack. She went to the local area, and that time her IOPs were 44, and in the left eye. And she came to us with 618 vision on 3 drugs, Brimo and dorzolamide with timolol, as well as Dimox BD with redness pain of 3 days on this maximal medication. And we see that the patient's IOPs are below 10. So she's now with, of course, the Van Herrick's grade 1, and the discs are normal. So agonio in the other eye also shows it is occludable, but fully opening up to scleral spur. And PI was done, and after the PI, the patient was asked to come back after a week. And so we have a hypotony post-acute attack on maximal medications, both topical and systemic. And after the PI, when she came back off all the medications, the IOP was still below 10, and then the patient was asked to go only on the steroid taper and stopped and come back again after 1 week, when she came back with an IOP of 30 this time. Next case, a similar one, presenting 5 days after an acute attack, goes locally with the acute at the time of the acute attack, and again on maximal medications, brinzolamide plus timolol plus brimonidine, the 3 AGMs with Dimox BD. Similar presentation, but coming with pain and for a second opinion on after 5 days of acute attack. But here the difference is the right eye actually has a lot of DM folds and glaucomflecken with a thin membrane on the IOL surface. Gonioscopy, because of the hazy view, could not be done at that point. So the other eye obviously was occludable. And so what next when you have 2 similar kind of presentations, both of them in the first case, hypotony on drugs, second case, borderline IOP 20 on drugs, but features of DM folds as well as inflammation with respect to membrane on the anterior surface of the lens and the cataractus lens. So in the second case, would you like to do any further investigations to assist you in your management? Anyone?
No, both the cases are actually, especially the second one, is a post-congestive phase of acute attack of glaucoma. So it will behave like this. It's not in a state of ciliary shutdown, but it's in a state of ciliary shock. So you will have low IOP. You have to pump up the steroids, and both the cases you should use pilocarpine. I am not in favor of using brimonidine. Brimonidine is a myotic, but unfortunately what it does is it doesn't cause the same meiosis as pilocarpine. It causes photopic myopsis at around 5 millimeters or less than that. Scotopic meiosis will stop at something around 5.5, 6.2 millimeters. So that's the maximum stage in which you get an acute attack. So if you are using brimonidine in a patient having an angle closure component or a PSCD, you have very high chances of having undiagnosed. You have very high chance of having going in for acute attack. So be very careful if you are using brimonidine, because it doesn't cause the pinpoint meiosis of pilocarpine, but it will bring the pupil to around 4 to 6 millimeters, and that's when you get a precipitated acute attack. So be very careful using brimonidine phakic eyes. So this is posted, you just use steroid and pilocarpine, it will start functioning normally. They won't have any other issues. Of course, you have to do PI after the cornea clears and the IOP comes down. Or in such situations, we do a surgical PI.
In the first case, Thomas, when the patient is coming back on the second week with IOP of 30, PI is done.
Okay, the thing is, pupillary block is not the only mechanism to cause closure. So when in doubt, one, do an ASOCT if it's available, to look for the lens vault. The lens alone may be the bigger culprit. The second thing is, in all these situations where a high IOP has been suddenly brought down, you can have a ciliocoroidal effusion as a consequence of the sudden dip in intraocular pressure, a transudation. So, B scan, UBM to look for the thickness of the choroid as well as to look for fluid behind is warranted as an investigation, but that ciliocoroidal anterior rotation of the ciliary body as a consequence should also be kept in mind. And both these cases, the cornea is bad, so you may not be able to see the next mechanism, that's the plateau iris. So other mechanisms have to be thought of. Okay. And if it is a ciliocoroidal, pylo is not a good idea. So we need to do a B scan before we go on to pylo.
Okay, so this is exactly what was done. You can see the glaucoma flecken here in the picture below, and an ASOCT was done in the right eye. At that point of time, the values were not, could not be read actually from the printout because of the corneal edema and bad cornea state. Only the CCT was in 764 compared to 542 in the other eye. But the other eye itself, the lens was thick. It was 5.17 mm and the lens vault was 1.24 in the other eye itself, giving an indirect hint about a thicker lens and a higher lens vault, like Thomas mentioned. So we'll need a cataract surgery. And when would you do the cataract, Dr. Gidija or Dr. Sai, anybody?
Once
The cornea is still to improve, and so. No, I don't bother about lens vault clinically because the cornea has got so many DM folds. Are you going to wait for cornea clarity, or?
the IOP is controlled or uncontrolled now?
IOP is around 20 and it's more or less controlled.
If the IOP is controlled, then you can wait for the inflammation to come down before going in, because with the inflammation, it's going to be even more disastrous if you do a cataract surgery then. The patient can have severe postoperative inflammation. So better to give systemic steroids to bring down the inflammation along with the topical therapy, and wait for some time, at least for 10 days before you go in.
Yeah, so the patient anyway, after 2 days after the PI, and you can see the sequence 2 days, 4 days and 18 days after PI, IOPs have always been below 10. But an important thing came up actually, we noticed 10 days after that the patient has a little bit of a subluxated phacodonosis of the lens. So this has turned out, and Lopa got the history of some blunt trauma having occurred to that eye, and that brought in the concept. And anyway, surgery was done, and this is the ASOCT picture after the cornea improved. And that time also you can see the lens thickness is 5.32. It is a thick lens. And finally, finally, a surgery was told to the patient a month. It took almost a month for the cornea to be better. And when the patient was told, he came back for the surgery with an IOP in that subluxated lens with an IOP of 40. So she then immediately underwent surgery. Dr. Minumathan was a surgeon. He also did a pupilloplasty along with the cataract extraction, and 10 days post-op pictures are shown here. So the third case, again, is a patient who has presented much later, 2 weeks after the acute attack. Patient actually, after a dental extraction, the patient had eye pain, and then patient went to a neurologist for the headache, did imaging, and then the neurologist sent to the ophthalmologist, and the patient there locally was treated by the ophthalmologist with all the anti-glaucoma drugs. So he's not only on the 3 drugs, also on Pilocarb, BD, as well as Diamox half TDS when they came to us. IOP was 34 at that point of time, vision was 6/24, and these are the pictures at that point of time. So again, after mannitol, PI was done. Patient was asked to go, asked to go and come back with the tapering medications, and the patient actually came back off Diamox with an IOP of 40, and so mannitol was given, and after mannitol, again the IOP was remaining at 40. So as we know that this is a patient which was presented much later, that is 2 weeks after the acute attack, and the other eye itself is showing some amount of synechiae on indentation. So what is your opinion, and how would you go ahead?
I think this is a very typical case where you have to do all the investigations. The first 2 cases you should have started pilocarpine, because I think pilocarpine was not started in those cases.
Yeah.
So
this patient came on pilocarpine.
So, I mean, these are the case where you have to show all the UBM and the ASOCT and everything. acute attack without managing with pilocarpine is going to be very, very difficult.
So here the options stand before you, like when the patient has come revisited you with an IOP of 40, cornea not clear, and cataractus lens, whether it's going to be a cataract surgery alone. We are expecting Sinec presenting 2 weeks post-attack. It's going to be a 360-degree Sinecal closure mostly. So are you going to do a cataract surgery alone? Are you going to do a cataract plus trab? Or are you going to do a trab alone? Not really. Early 0.7, 0.6 to 7, but subtle superior notch. Not very glaucomatous.
Anyway, this goes with the classical teaching, with 2 weeks of closure and you'll have Sinec. So you got a compromised angle, and obviously the answer is surgical. I would throw in a trab along with the cataract surgery in this case. There is cataract, right?
There is significant cataract.
Then it's the distance easier. I would like to get the lens out to create space. So I would throw in a cataract surgery and a trab in this case. And
even though we are not sure whether it is a moderate glaucoma or not.
It doesn't matter because the outflow, we expect Sinec all around. So we would throw in a trab, or rather I would.
I would do cataract alone and wait and see how the glaucoma does, because the history is not very long, to really warrant filtering surgery along with that. And obviously the eye is inflamed. Putting in one more surgery, it's not my choice. So I would do a cataract alone, see how the glaucoma does, but tell the patient that you may need a filter later on. But primarily cataract alone.
So Lopa, actually I'll give it to her because she operated this case and she did a cataract alone. And these are the post-ops up till day 1, day 4, day 12, day 22. 3 weeks post-op also, IOP is below 10 and low diffuse bleb. And that's it. Cataract, no, trab alone was done.
It was very hedgy cornea. It is a microcystic edema and post-manital IOP was 40. So I did only trap because there was no view. So I think over 2 weeks the pressure came down to 9. So I thought later I'll do a cataract.
So the general consensus with the WGA is that you do attack also, they're encouraging you to do a lens removal, but we have to be careful that the phacoemulsification itself can cause 5 to 10% endothelial cell loss. Acute attack has been shown to cause 10% cell loss, endothelial cell loss. So we have to be careful when we do intraocular procedures.
Okay.
And also, it's not great fun doing a cataract in these eyes with such slit anterior chamber.
Yes.
I mean, of all the steps, I find Rex is the most difficult. I'm very scared I'll hit the decimates from the other side.
So finally, the debate goes on in such cases, and what works best in one's hands also matters. The next, again, I'm still continuing with my post-acute angle closure patients. This lady came to our casualty on a Sunday with 1 hour duration of blurred vision, and she was noted to have a 58 IOP, and the senior consultant was called by the resident doctor, and conservative treatment was advised at that point of time and advised to come the next day for a PI. So next day, the patient presented to the consultant with IOPs down to 4 with the medications, Combigan, Diamox, and Van Herrick's of grade 1, but clear cornea. PI was done by the consultant who saw on the next day, and the patient was advised to come after a week. So patient presented on 3rd for the PI, and 1 week later, you can see that not just the IOP was normal, as well as the PIs were documented as patent by that consultant, and the gonioscopy done showed no PAS, indentation opening up to scleral spur, and no choroidals was noted also. So comfortably the medications were stopped, tapering of steroids was told, and patient was advised to come after a month. But now she comes back to myopia with just 3 to 4 hours after going back home, because the previous day everything was normal. The patient was routinely dilated to have a look at the fundus in the retina clinic. So post dilatation, she comes back then after 3 to 4 hours with very high IOP of 62. So she presented with pain and headache, and IV mannitol was given. The IOP came down with that along with Diamox to 24. The corneal edema has reduced, But at this point, especially when a consultant has documented and written on the file that the PI was patent, I was very hesitant to do PI at another location because I thought the peripheral iris thickened rolls are probably covering up the PI, which we are not able to see. So under pilocar, probably I'll see the next day evening after 24 hours. Maybe it will improve. There's no need for another PI. So I send the patient back. But instead, I would actually take an opinion as to of the panelists. At this stage, when you are not seeing the PI, pupil is a little mid-dilated, but patient is improving, cornea clear after mannitol. Are you going to do a PI at another site today, or are you going to wait till the next day? Anybody can put in.
No, the thing is, once you break the closure and keep the patient on aqueous suppressants, we usually don't get the closure back immediately. So it is preferable, in my opinion, to reassess after a significant amount of time, after the pressure has come down and the eye is sort of more physiological, and then decide on that.
That's what I did actually. I did not do a PI that evening. I told the patient under medication I kept her on observation, but she came back the next day, morning itself, with IOP of 48, and she was very upset that it's all come back again. And because I had sent the patient on Pilopar, this time when the patient came, though the cornea was a little edematous, I could see the patent PI as documented by the other consultant. Patent PI is definitely there. Still, the patient had gone for an IOP spike at this stage. So I was kind of forced to put another PI, and cornea was hazy, so I put at the collarette, which I hate to put, but I relieved the block and I put at the collarette and things improved. And these are the pictures. As you can see, I've shown in the black arrow, the PI is patent. Despite it, it had recurred. So what are the possibilities of recurrences despite a normal patent laser iridotomy? Possibilities that can be thought of.
You have to see a UBM and a ASOCT, see how the angle looks like, and especially UBM.
Well, she was in a lot of pain and all that. So
the other thing is when you're giving mannitol, you can start pilocarpine as it's going. So the mannitol also gets finished, you get the effect of pilocarpine also, and you can identify everything in the same sitting. Sometimes the nurses don't put pilocarpine when mannitol is going. They think it's has to be done after the procedure or something like that. So if you instruct them, get pilocarpine into the eye as the mannitol is going. So every would have done in the evening itself.
So you can see that white arrow actually, to break the block, I put at the collarette a PI and things settled down with that. And then, like you said, a gonioscopy suggested a plateau iris. She's probably a case of plateau iris. The left disc after all this recurrent attacks of IOP rise was a little edematous to look like, and a little artifacts in the field as well on the left eye. And ASOCT done actually showed that the lens thickness was quite okay in the right eye, but asymmetric in the left, 4.8 in the right with a 5.1, and a lens fault more than 1 in the left eye. So is the larger, thicker lens in the left eye a culprit, or is it plateau iris alone? We don't know. The discs were normal, correspondingly follow-up fields were normal, and so this has already been discussed. But what exactly would like to look at in the UBM, Dr. Ganesh, if at all we were doing a UBM? The plateau or?
Ciliary processes where they are rotated forward, and any other pushing mechanism, any cyst, all those things could play a role.
Yes. So iris is correct.
The acute attack, as Dr. Thomas mentioned, it's not one particular mechanism. There are multiple mechanisms at play. And there is some correlation, the size of PI versus the response to multiple mechanisms put in toto.
So the thing of concern now is, whenever in future also if the patient gets dilated, will she come back to us again with an IOP spike, especially if she's a plateau? That concern is there. And the role of clear lens extraction, no sine K at all, it's an open angle, IOP right now controlled, disc normal, plateau iris sitting there, a larger, thicker lens. So Dr. Sai?
If you get one more dilating attack, I would
Go for clear lens.
Yeah. Basically, I'm a cataract surgeon more than a glaucoma surgeon. So, so I think
Anyway, I sent her home saying that this time it's all settled. She'll never ever get an attack till she gets dilated. And I told with so much of confidence that I was upset to see her come back again 2 days later with such kind of a picture of red eye. And she was, and I see that the pupil is well constricted, but the eye is congested. But I had to convince her that it's not IOP at the culprit. This time it was abrupt stopping of Predfort, which was the culprit. So I shifted her to Lotipred, and she's a happy patient now. So we move on to the next patient, a young girl who is a doctor and who came for a general opinion referred by an in-house ophthalmologist from her institute about the anisocoria. And you can see that, I don't know how clear the picture is, but you can see that the pupil is peaked towards the supratemporal area, and you can see adhesions right from here till 2 o'clock, mid-peripheral adhesions. Otherwise, her best corrected acuity is normal, IOPs are normal, and so this is a case of eye syndrome, probably a progressive iris atrophy. Just wanted to take the opinion of the panelists as to what is the role of ASOCT. Should a raster scan and a cube scan be done in all cases to delineate the mid-peripheral PAS? Because by gonioscopy, it is difficult to know whether it's a 360-degree synechia, or in this case especially, there was just a little bit of a supranasal area which is paired, I think. Mid-peripheral, from our gonioscopy itself and anterior segment evaluation itself, from say about 5 o'clock to 2 o'clock, I thought there is mid-peripheral PS. But when I did this raster scan, actually, I could delineate a better picture, and I could delineate that just about 2 clock hours supranasally, we don't have a mid-peripheral PS. So I personally feel ASOCT raster scan is helpful in this scenario. Any opinion or any further?
I'm sure Ganesh and Thomas see more glaucomas than I do. But many of these unilateral eyes cases, especially in young and middle age, they remain stationary for a pretty long period of time. That has been my experience. So we can document all these and keep, but don't be very aggressive in these sort of things. So with medication in the endothelial, follow up the endothelial count, look how they are progressing, have a look at the discs. But many of them do remain stable for a very long period of time.
So discs are normal, and the endothelium is showing thick CCT in both eyes, 610 CCT in the right and 607 in the left. Some kind of eye cell-like appearing cells are there in both. So
how old is she?
46.
46. So if she doesn't have any symptoms,
And her IOP now is 20 in the right.
20 in the right.
And the other is 12.
So if she doesn't have any symptoms, we can
No symptoms. It's not affected by glare at all in the...
That ASOCT is actually very helpful to identify if at all the intraocular pressure rises. You have a supranasal area where you can place a trap. Although the angle is not totally blocked, they will still filter.
Yeah. Move on to this next case. She is a 48-year-old lady, POAG suspect. She's been on treatment from Arvind onwards, 20 years on a combination of prostaglandin with beta blocker. Very happy with the asymmetric POAG. She comes all the way from Kollam nowadays because she's not able to go up to Arvind. And she's very happy because she has a very minimal field defect right from Arvind days and maintained well. But now she has a 618 best corrected vision in the right eye, little bit of blurring. So she has a little bit of cataract. CCTs are normal. The disc also is more mild glaucomatous with an inferior notch and inferotemporal thinning. So finally, she was advised cataract surgery, and the option of an MIGS with a cataract surgery was given to her to get rid of the medication. So this is her disc. The right, you can see the inferotemporal wedge and the inferior notch in the right eye. The early nasal defect in the right eye, which is stable right from 2018 onwards. the OCT serial picture showing you from 2018 to the time she got operated, that is November 24, that her average thinning as well as her infratemporal clock over thinnings are stable. And she underwent cataract surgery, uneven full with Tanito microhook. Again, Lopa has done this case. And the patient comes back 1 week later. She goes to our Kollam branch with a IOP of 60. A lot of headache and very disturbed. Mannitol was given, Diamox was given. She was already on Pilo post Tanito, TDS, and Combigan was added. And the next day she comes to our base hospital. IOPs are well controlled with the mannitol post and tablet systemic carbonic anhydrase along with the topicals AGM. Everything was well controlled the next day. And the occasional cells, about 2+ cells were seen. And so the Gatilox DM, which was a steroid, it was stepped up and the patient was sent back. And 2 weeks later, the patient comes back with IOPs of 28. And that time, again, the AC has appeared quiet. So the 2 to 3 weeks, that period, the pressure was just going up despite all this. And at 3 weeks, despite it, she came with 54. IOP started building up. So the concept of steroid response was thought of. And Gatilox DM was totally replaced with Acular LS because the eye was quiet. So it was replaced with a topical NSAID. And 1 month when she came back off Diamox, it was maintained at around 22. So after that, off Diamox on the topicals AGM, mind you, the Pilo continuing at TDS, the IOPs came down to the range of 17 and gradually it's been coming down and maintained at around 10 to 11 to 12 by about 8 weeks of surgery, and patient is only on Acular. But by about 3.5 months, 3.5 months down the line, again occasional cells come up and patient is having an IOP from 12, it has gone up to 22 with occasional cells. And so this time loteprednol was started. And soon after starting loteprednol, again in 2 weeks time, the pressure has gone up to 30. So definitely in the background of minimal inflammation, whenever steroids are start, there is within 2 weeks, despite all your medications, it is spiking up all the way. So now, of course, she's well controlled. Otherwise, Travacom is always there right from Arvind days. So that we have shifted in the operated eye also on Travacom, and she's comfortable on 12. But and at that point of time when she came for review, there was a little bit of a doubt whether there is a reverse pupil block and whether there is a peripheral concavity of the iris. That is why to know that this ASOCT was done, but the iris contour looks very much normal on the ASOCT. And the gonioscopy shows not much of pigment dispersion. It's almost okay. And this is the nasal area where the attenuator is done, and you can see the area here. Glistening. So here in a chronic POAG with a stable visual field defect, are we really justified in combining with an MIGS? Number one, would a cataract surgery alone, would it have been sufficient? Secondly, whenever you have minimal inflammation, recurrent post-op IOP spikes, can we have accelerated steroid responses in adults as well? So does this chronic AGM therapy have any role in this whole process? Because she's been on treatment for 20 years. Open to anyone.
To keep them on Pilo?
1 month to 1.5. 6 weeks I keep her Pilo.
So I'll tell you my protocol and what we follow in Arvind Eye Hospital, Coimbatore. It's different from other centers of Arvind. We use steroid which is Predfort 4 times a day only for 10 days. Post any mix, whether it's eye stent, KDB, Tanitos, Bang, anything. Pilocarpine for 3 times a day for 10 days. Amplinac, no financial interest, for 3 times a day for 30 days. And Orofox, 4 times a day for 15 days. We don't get any spike at all.
Yeah, this case is actually something that I can't figure out what is going on. Because day 3, 4, when the first spike happened, is too early for a steroid response in any case, 60. That we can blame only on something like inflammation
Or
or
dispersed heme, probably.
dispersed heme or retained OVD. Those are the only things that can happen in that short time. Then if that was the only thing that was happening, 2 weeks down the line, the patient should be okay. But the patient is still spiking once in a way, and steroid response, however accelerated on loteprednol, which is a very weak steroid, is still something that I wouldn't expect 60, 50 and all.
Yeah.
They're very high pressures.
Yeah.
There is something else happening. One thing we should realize about MIGS is we are dealing with trabecular resistance, and when we see an open angle, we do not really know if the resistance is in the trabeculum or in the post-trabecular pathway. You can have it, things which we have not defined yet. So we may be looking at something else altogether also, which we don't know.
Not exactly, no, it won't be there. It won't. Why it happens is because when you remove the trabecular meshwork, the outer wall of the shrams can also react to steroid. How it reacts has never been studied because you never put steroids in a structure which after you remove the inner wall and then you put steroids in the outer wall. So the outer wall is adjacent to the collector channels and they respond to steroids very severely, I believe. And they are the ones which block the opening of the collector channels. So from day one, you get a spike. This happens very commonly in pediatric cases. So pediatric cases on day one, we put only loteprednol. So, and we use pilocarpine for all cases because the cut tissue, iris will go and stick to anything which has been cut, you know. So whether it's a rexus margin, people go and stick to the rexus margin. Then you get intraoperative, you know, raised shallow chamber and all that. If it's a wound, it will go and stick to that wound. So we pull the iris away from the structure there so you don't get pus formation. And since you want to switch off steroids within 10 days, so you use NSAID for 30 days to compensate for that. So this is how we have been managing all our cases. But other centers, unfortunately, they are using steroids huge, like pump steroids 8 times a day. So 8 times a day is really going to be very difficult to, you know, the response is so paradoxical that you won't know what actually has been happening in the eye.
I too haven't seen much of a response with loteprednol like this going up to 60s and all.
We don't use
So I
steroids.
personally also don't feel this is steroid response alone.
So normally we give 6 times, but there is only
We
2.
give only 4 times. In Coimbatore, 6 of us operate. We give only 4
Okay,
times.
now I think we'll move on to the last case. Now she is a myope, 57-year-old lady, a myope, who did LASIK in both eyes in 2008. She had a pre-LASIK myopia of minus 14.5 right eye and 10.25 left eye. And after that, she also underwent a cataract surgery in the right eye, post-LRCS and post-YAC cap as well. Somewhere around in the local area, she was diagnosed as a glaucoma suspect 2 to 3 years back. She came to me on brinzolamide in both eyes twice daily. And after she came here, AGM, the anti-glaucoma medicine, was discontinued in both eyes, and the patient was asked to review after a week and after a month. And at both occasions, GAT, Goldman applanation in post-LASIK eyes, though I know that has got a lot of fallacies, but always compared to the first IOP checked, we can compare and see whether there is a profound rise on stopping. It was maintained at 8 in the right eye and 12 in the left eye. So she was kept on observation and she underwent a DVT also on without any medication, and she was found to have a fluctuation of 8 to 11 in both eyes. This is post-LASIK pictures of the patient, and the gonioscopy was normal, open. And these are the discs, much more myopic discs with a lot of pallor element, a large area of peripapillary atrophy in the right eye. It looks more pale, it was more myopic, the right eye. Left eye also has peripapillary atrophy, and in accordance you have the enlarged blind spots on the fields. But in the left eye, are we dealing with a few paracentral area defects in the superior germs area? Is this an early glaucoma? Is the thing of concern. Are we safe taking the patient off medication? Is another concern. And this is finally when she came to me, the GPA summary, which again shows that it is stable in the left eye, though labeled as a probable disc suspect, but kept on follow-ups without medication, on IOP checks alone, and feels at 6 monthly intervals. Any role these OCT scans have or not in myopes is doubtful, but because the fundus evaluation even in the retina clinic shows an absolutely normal posterior pole and macula, probably a GCC may be helpful in such cases. So we have here a post-LASIK 16 years myope with pre-LASIK thin CCT, off brinzolamide, DVT showing normal fluctuations, field showing probably a stable early field defect, and what is going to be the plan of action. It's always controversial, but in myopes, as it is, myopic neuroretinal rims are difficult to assess, but post-LASIK eyes with IOPs also having fallacies, it is indeed difficult to follow. So are there any guidelines for IOP check in post-LASIK eyes with glaucoma suspicion? And what should be the ideal periodicity of visual fields and any role for OCT?
Currently on medication.
I took the medication off, so she's being followed up now for past 1 year, 1.5 years.
There is one more risk factor. I would keep her on medication. Maybe I'm being a bit strong family history, something like that, because ECT is unreliable in this case. So if you have one more
Risk factor?
yeah,
Okay, then it is worthwhile.
I would keep them on medication. I wouldn't take off medication.
Until we actually show a glaucomatous progression in this case, we don't know that it's a glaucoma. A myope with that much of peripapillary atrophy, all with choroidal sclerosis that's sitting there, and pallor out of proportion to cupping, you would expect a large blind spot, especially temporal sector defects and things like
These defects are the defects of concern, actually, the only.
Yeah, you look at the fundus there, you got white choroid there.
Yeah.
You got something else from myopia happening there.
Yeah.
And that peripapillary atrophy is coming down further there. So you will never be able to say this is myopia, this is glaucoma, until you show a glaucomatous progression. And this patient doesn't have near blinding visual field defects, so you can afford to follow up. And here, it's not just the CCT that's a problem. IOP also, we have no idea how to measure and be reliably measuring it. And applanation pre and post LASIK, if you had recorded in those days, you have some sort of an idea of what is the difference you expect. There are studies from LVP, that's research studies, saying that it's more reliable to do a SHIOTS on the sclera. I don't personally do that too much. On the temporal side is more reliable than applanation in these eyes. I really don't know much about that, but that is been published as a more reliable way of getting the IOP.
Dr. Ganesh, the protocol that you follow in
Arvind
for
what we are looking
LASIK
at is endpoints of progression. We are looking at endpoints of progression. Look at the disc very carefully. You don't always need to have you need to have fundus photo, but always you can compare that with the disc examination. You will have some features of progression if you look carefully. That's one. So take a good baseline photograph and compare your examination with that baseline, always. That's one. Number two is visual field. So visual field you have to do serially. Barring those areas which are defective, any more points which come in, there are endpoint of progression. Again, intraocular pressure. If it widely fluctuates, you can do a diurnal and see. Widely fluctuates, that's again an endpoint for progression. So OCT also, many people say that myopes, of course, OCT is not very reliable because OCT works in an axial length of 22 to 28 millimeters. Beyond that, it will give you a default. But always look at the cup. The cup, if you take the OCT image, you can always get later on, using AI, you can get some information out of it, looking at progression. So these are the endpoints of progression which you are looking at: intraocular pressure, disc examination, and visual field examination.
Thank you very much. I think I'm stopping on time. I thank the delegates for such a wonderful attendance here, and I'm sure you're all walking back with a lot of clinical pearls. And I thank all the panelists. A big thanks to all of you. I invite Sai sir to present a memento to Dr. Ganesh. Memento.